it's really a watershed study for a number of reasons. One, because it's really the first and only IO regimen to show, a relapse-free survival that has now stood up over time, and if anything, has gotten more robust over time, despite the fact that these patients stopped therapy at a year. And when we used our tyrosine kinase inhibitors in this setting, sunitinib was the only one to show a benefit, and we saw that benefit, at 2 years, but it's the curve started to come together as the patients came off the drug at year 3. We don't see that with this regimen. We see that there is a separation early on treatment, and it stays separate and gets, if anything, wider over time. So it's really validation of that. But even more importantly, what the latest finding at GU ASCO showed is that there is a statistically significant and clinically significant survival benefit associated with the adjuvant use of pembrolizumab. That's fascinating to me. It's fascinating to me on several levels. One, because I think it validates to some extent that the progression-free survival data is important, and it does translate into a longer-term endpoint overall survival. Two, that we're seeing this signal relatively early. This is a patient population that has a lot of treatment options to follow, and it's a patient population historically that can live a long time. So to be able to see that separation in what really amounts to the most aggressive cases, these are the patients that are dying early from kidney cancer. These are the patients we need to be the most aggressive on, and in that group of patients, we're already seeing the adjuvant use of pembrolizumab making a difference. So it's not just kind of slowing the progression of slow disease. It's actually treating and maybe curing patients that otherwise are going to die from this disease. And that's really fascinating. And I think the third aspect of this that, still to me is a bit of a enigma is how positive this study is and versus the negative signals we've seen with the other 3 adjuvant IO regimens. And it really does speak to, potentially differences between these agents in kidney cancer. And I think we cannot discount the fact that there could be real differences between them, and that this isn't, a fluke. This isn't a statistical abnormality or something. This is real. This is multiple endpoints. This is standing up over time. This is an international prospective randomized study. This is, consistent with the thinking for why we did all these trials in the first place. What we need to understand is what is different, whether it be in the agents themselves or the setting or what have you. But ultimately, I think it really does establish as, the standard for managing patients with high-risk localized kidney cancer, adjuvant pembrolizumab. And hopefully a platform to build off of, to build out additional therapies and make it even better. There's 2 things to this. One is that every adjuvant trial we've done to this point in time has had a placebo. And when you have a placebo, patients aren't particularly enthusiastic about signing up for a study that's going to require regular follow-up, regular visits, evaluations, extra tests and imaging and everything just to get a placebo. Now, I think for going forward, we're going to be able to offer real therapeutic benefit to patients in the control arm of our studies with pembrolizumab. And that's going to help with accrual. It's going to help with, standardization of this approach in regular practice. And I think normalizing adjuvant therapy in kidney cancer. So I think that's a really important aspect. And then I think when you look at the side effect profile of pembrolizumab in the adjuvant setting, this is something that I think we can absolutely build off. And we are. There have been already an adjuvant study completed. We don't have the results yet with belzutifan. In this setting, we're getting ready to launch STRIKE, an NCI-sponsored cooperative group study of short-term tivozanib and pembrolizumab versus pembrolizumab in this setting. I think you're going to see more and more opportunities for us to do studies. And my hope is that we're going to get smarter. We're going to understand a little bit more the profiles of patients who are most likely to benefit from adjuvant therapy, and be able to focus on those populations. Again, those highest risk patients for relapse early, the patients where, you know, we're seeing the survival benefit, and hopefully be able to build on it even further.